Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this session, I will be discussing a very important topic in the connective tissue disorders, that is the Behcet syndrome. So first of all, if you see the Behcets, it is the clinical condition which is commonly seen in the young individuals, and it is the disorder where you have recurrent aphthous oral ulcers. That is a hallmark of this particular Behcet syndrome. And not only recurrent oral aphthous ulcers, there are also recurrent genital ulcers that you will see in patients with the Behcet syndrome. And that is the reason why this particular Behcet syndrome, another name of it, it is called as oro-oculogenital syndrome, right? Oro-oculogenital syndrome, right? So this is another name of the Behcet syndrome. In the sense, there will be ulcer formation within the mouth. There are also ocular manifestations in the form of anterior and posterior uveitis, and there is also the genital ulcers, recurrent, and that is the reason why it is called oro-oculogenital syndrome. And this particular Behcets, I have already said you, it is very common in young people, and that too of age group around 20 to 30 years. Right, the first symptoms they develop, around 20 to 30 years, right? That is what you will see in Behcets. Now, another point is, what is the HLA association in the Behcet syndrome? This is a very important question. The HLA association in Behcets is the HLA-B5 or HLA-B51, right? This is the HLA association that you will have in patients with the Behcets. So, in those individuals who have the genetic HLA-B51 or B5, they are more prone for the development of this particular Behcet syndrome. Now, if you see the countries in which you see this Behcet syndrome, most commonly it is present in Turkey, right? Most commonly it is present in Turkey. And the other countries where you can have this Behcets is in countries like Iran, Saudi Arabia, Greece, Japan, and as well as Korea. And we also see this in China. But most common where you will see this is in the Turkey. Now, let me move on to the discussion of the clinical features in patients with the Behcet syndrome. And what exactly is the etiology is not known, but it is seen in those individuals who have HLA-B5 and as well as the HLA-B51. So I said you this recurrent oral ulcers, that is the hallmark, okay? So the presence of aphthous ulceration, right, it is the hallmark of the Behcet syndrome. And this oral ulceration, if you see, they are very painful. Right, they are very painful aphthous ulceration which you see within the mouth. And these ulcers, whenever they appear, they are almost 2 to 5 in number. Right, they are almost 2 to 5 in number. And this recurrent oral ulcers, it is the sine qua non for the diagnosis of the Behcets. Sine qua non means this particular recurrent oral ulcers should be there to diagnose Behcets. Without this, we cannot call it as Behcets. And it is this recurrent oral ulcers, these are the earliest manifestation in these patients with the Behcets. Now, what are the sites within the oral cavity you have the presence of these ulcers? These ulcers, which are multiple, they may be found on the tongue, right? They may be found over the gums and as well as the inner surface of the oral cavity. right, inner surface of the oral cavity. So these are the areas within the oral cavity where you have the presence of the ulcers. And these ulcers, I said you, they are very painful. And not only that, if you take the size of these ulcers, right, they are very smaller in size, small, shallow aphthous ulcers. And I said you that these are recurrent. And how many times they appear within a year? They almost appear 3 times in a year, right? They almost appear 3 times within 12 months period. And after the appearance of the ulcer and a period of time, the ulcer will present and it will disappear. And whenever it disappears, there is no scar formation. Okay, so these ulcers, they subside without scar formation, right, without scar formation. Okay, right, and whenever the ulcers appear, they are almost like 2 to 5 in number. So this is about the aphthous ulceration, that is recurrent oral ulcers. Then followed by that, the genital ulcers. See, genital ulcers, these are little less common than compared to that of the oral ulcers. Okay, right, these genital ulcers, these are less common than compared to that of the oral ulcers. And these genital ulcers, whenever they subside, these are also recurrent ulcers. But whenever they subside, they leave a scar. Okay, genital aphthous ulcers occur slightly less compared to that of the oral ulcers, but whenever they subside by forming a scar over the genital area. Okay, that is about the genital ulcers. Then coming to the ocular lesions. See, the ocular lesions will be in the form of ocular inflammation. And this ocular inflammation, this is the hallmark, right? This is the hallmark manifestation of the Behcet's disease. And this ocular lesion, it is in the form of both anterior and as well as posterior uveitis. Right, there will be both anterior and as well as the posterior uveitis. Okay, and there is also development of retinal vasculitis. Right, there is also development of retinal vasculitis. So these are the ocular lesions that you will see in the Behcets. Now this particular eye involvement, this is one of the most devastating complications of the Behcets. Right, now if you take this anterior uveitis, this anterior uveitis, it is associated with a triad. Right, it is associated with a triad. So whenever the individual develops anterior uveitis, this will be the triad of manifestations that includes photophobia, right, then followed by that there can be blurring of vision, then the development of red eye, right, development of the red eye. So this is a triad that you will see in patients with the anterior uveitis. And as a part of the posterior uveitis, there may be destruction of large areas of retina. Right, as a part of the posterior uveitis, there will be destruction of large area of the retina. Right, and because of the destruction of large area of the retina, the individual will develop the visual problems. Now, as a part of the anterior uveitis, we have discussed this is a triad, that is photophobia, blurring of vision and red eye. But if you leave the anterior uveitis without treatment, what will be the complication that you will see? Right, what is the complication of anterior uveitis? So, as a part of the anterior uveitis, there can be accumulation of pus, right, there can be accumulation of pus in the anterior chamber. So in order to see that the pus is drained out, right, in order to see that the pus is drained out, you need to give a mydriatic agent. Right, you need to give a mydriatic agent. Okay, so if this anterior uveitis, where there is accumulation of pus in the anterior chamber, if it is not properly treated with mydriatic agent, so this mydriatic agent, what it will do, it will cause the dilatation of the pupil. And along with the mydriatic agent, you need to give steroids. Right, along with the mydriatic agent, you need to give steroids. And when you give steroids, what these steroids will do, it will diminish the inflammation. Right, it will diminish the inflammation. So whenever there is accumulation of pus in the anterior chamber secondary to anterior uveitis, you have to give both these, mydriatics to dilate the pupil and steroids to diminish the inflammation. If you don't administer these two agents, then that will lead to synechial formation. Right, that will lead to synechial formation between the iris and as well as lens. Right, synechial formation between iris and as well as lens. And once there is synechial formation between the iris and lens, that will result in permanent pupillary distortion. Right, that will lead to permanent pupillary distortion. Okay, so that is about the complication of the anterior uveitis. Right, so ophthalmic manifestations will be in the form of anterior and as well as posterior uveitis. And these ocular lesions, they are the hallmark manifestations of the Behcets. And as the part of the anterior uveitis, the triad what you will see is photophobia, blurred vision, and there can be development of red eye. And as a part of the posterior uveitis, there can be destruction of large area of retina, and that is the one which will make the individual to have visual problems. And the complication of the anterior uveitis is that there will be formation of the hypophion, that is the accumulation of pus in the anterior chamber, and if it is not treated properly with mydriatic and as well as the steroid, the anterior uveitis may lead to synechial formation between iris and lens, and that will cause permanent pupillary distortion. So that is the ophthalmic manifestation in patients with the Behcets. Then followed by that, the skin manifestations. See, the cutaneous manifestations, they are seen in almost 60 to 90% of patients with the Behcets. And that cutaneous manifestation, it is in the form of erythema nodosum. Right, so erythema nodosum is the cutaneous manifestation. Right, it is a cutaneous manifestation that you will observe within the lower limbs. Okay, right, where there is inflammation of the subcutaneous fat. And apart from erythema nodosum, the other skin abnormalities that you can observe is acneiform nodules. Right, acneiform nodules. Acneiform nodules in a post-adolescent patient not taking glucocorticoids, you have to think of this Behcets. Okay, right. And another important skin manifestation is pseudofolliculitis. Right, pseudofolliculitis or papulopustular lesions. So these are the skin manifestations: erythema nodosum, acneiform nodules, pseudofolliculitis or papulopustular lesions. Now, if you see about this particular erythema nodosum in detail, this erythema nodosum, it is the skin lesion that is seen in the lower limbs, and it is tender and erythematous. Right, it is tender and erythematous papular lesion. Right, it is tender and erythematous papular lesion. And when you do a biopsy of this erythema nodosum, right, when you do biopsy, these lesions, they show the presence of the septal paniculitis, right? So you have to remember one point here. Erythema nodosum, it is also seen in sarcoidosis, right? And the erythema nodosum of the Behcets, they have the tendency to ulcerate, right? They have the tendency to ulcerate. And this is the major difference between the lesions of Behcets and erythema nodosum seen in sarcoidosis and inflammatory bowel disease. So this erythema nodosum, it is also seen in patients with the sarcoidosis and also seen in patients with the inflammatory bowel disease. But how will you differentiate erythema nodosum of the Behcets from sarcoidosis and inflammatory bowel disease is that the erythema nodosum of the Behcets, it tends to ulcerate, right? It tends to ulcerate, okay? And on biopsy, many of these lesions are shown to be secondary to vasculitis, right? Secondary to vasculitis. So why is this erythema nodosum in Behcets? That is secondary to vasculitis. Okay, next. So this is about your erythema nodosum, right? And I have also said you how to differentiate the erythema nodosum of sarcoidosis and inflammatory bowel disease. Then we have another important skin test that is called as the Pathergy test. So the Pathergy test is the test which is done in patients with the Behcets to diagnose the Behcet syndrome. So what you have to do is, you have to give intradermal injection intradermal injection of 0.1 ml isotonic solution. Right, 0.1 ml isotonic solution has to be injected. How much? 0.1 ml. And with the help of, with the help of a 20 gauge needle. Right, with the help of a 20 gauge needle. And whenever you inject, you have to inject to a depth of 3 to 5 mm intradermally. Right, you have to inject 3 to 5 mm intradermally at an angle of 45 degrees. Right, at an angle of 45 degrees you have to inject. And the test is read after 24 to 48 hours. Right, the test is read after 24 to 48 hours. And for suppose, if there is development of erythematous papule, right, if there is development of erythematous papule or pustule, right, and this erythematous papule or pustule should be of more than 2 mm in size, then we consider it as a positive Pathergy test. Right, I'll repeat everything once again. What you need to do, you need to take 0.1 ml of normal saline and you have to inject that intradermally to a depth of 3 to 5 mm at an angle of 45 degrees with the help of a 20 gauge needle. And the test is read after 24 to 48 hours. And when will you consider the result to be positive is when there is development of erythematous papule or pustule of more than 2 mm, then we consider it as a positive Pathergy test. Next, after the skin manifestations, so until now, like what all we have discussed in Behcets, recurrent oral ulcers, very important, that too painful ulcers. Recurrent genital ulcers, scar formation will be there but less common than compared to that of the oral ulcers. Then ophthalmic manifestation, that will be in the form of anterior and posterior uveitis. and then followed by that skin manifestation, and that is in the form of erythema nodosum and as well as the acneiform nodules. Then positive Pathergy test. Then you take the central nervous system involvement in patients with the Behcets. See, this central nervous system involvement is another major cause of morbidity in Behcet syndrome. Now, what will be the findings? That includes in the form of sterile meningitis. Right, that includes in the form of sterile meningitis. So, the individual will have recurrent meningeal headaches, and that is associated with lymphocytic pleocytosis. Right, so when you do a CSF analysis, you don't have any organism there, but you have increase in the lymphocytes within the CSF. Alright, then the another important central nervous system involvement will be in the form of cranial nerve palsies. Right, cranial nerve palsies. And there can be inflammation of the brain parenchyma, and that we call it as encephalitis. And there can be mental disturbances. And spinal cord lesions. Right, spinal cord lesions. So this is the central nervous system involvement that you will have in patients with the Behcets. Right, and radiologically the central nervous system lesions, it may mimic multiple sclerosis. Right, it may mimic multiple sclerosis. Okay, then GI manifestations. So you will have aphthous ulceration within the GIT also, and this aphthous ulceration within the GIT, it is mainly located within the ileum and as well as within the cecum. So this is where you have the GI manifestations in patients with the Behcets. Then vascular involvement. See, just now we have discussed the erythema nodosum is secondary. When you take a biopsy of erythema nodosum, it has been found to be secondary to vasculitis. And what type of vasculitis that you will have in Behcets is large vessel vasculitis. And you should know which vessel is involved in Behcets. Right, which vessel is involved. So large vessel vasculitis that can lead to pulmonary artery aneurysm and life-threatening pulmonary hemorrhage. So pulmonary artery is affected, and thereby the individual will have pulmonary artery aneurysm, and then pulmonary hemorrhage. That is what you will have the vascular involvement. Next, followed by that, in patients with the Behcets, they also have the hypercoagulable tendency. Right, they have the hypercoagulable tendency. And because of this particular hypercoagulable tendency, that may lead to complicated venous thrombotic events. So there will be venous thrombosis, and particularly deep vein thrombosis, and there can be also development of pulmonary emboli. There can be cerebral sinus thrombosis. Right, there can be cerebral sinus thrombosis. So these are the hypercoagulable manifestations that you will see in patients with the Behcets. Next, followed by that, the joint involvement in Behcets. So joint involvement will be in the form of arthritis or the spondylitis. right? That will be in the form of arthritis or spondylitis. And this joint involvement, it is seen in half of the patients. Right, it is seen in half of the patients. And this joint involvement, it may be monoarticular or polyarticular. Right, monoarticular or polyarticular. And the joint involvement, it is non-deforming in nature. That means you don't have the deformities within the joints whichever are affected in patients with the Behcets. So this is about the joint involvement. And the pulmonary involvement, just now we have discussed, that will be in the form of pulmonary artery vasculitis. Right, that will be in the form of pulmonary artery vasculitis. And secondary to this, the individual can have dyspnea. Right, the individual can have cough and chest pain. So that will be the pulmonary involvement in patients with the Behcets. So remember now, Behcets, it is a multi-system disorder, right? I'll just point out one by one. First one, the recurrent oral ulcers. That is a hallmark of Behcets, and it is a sine qua non of Behcets, and it is the earliest manifestation in Behcets. And the ulcers, whatever you see, they are very small ulcers. They are very painful ulcers, and they appear almost like 2 to 5 in number whenever they appear. And they appear almost like 3 times in a year. That is a feature of your recurrent oral ulcers. Then genital ulcers, these are less common than compared to that of the oral ulcers. But whenever they subside, they form the scar formation. And ocular manifestation, that will be in the form of anterior and as well as posterior uveitis. And due to which the individual will have the visual impairment. And as a complication of the anterior uveitis, there can be accumulation of pus in the anterior chamber, and for which you need to give mydriatics and as well as corticosteroids. Otherwise, the individual will develop permanent pupillary distortion. And skin involvement will be in the form of erythema nodosum, acneiform eruptions or acneiform nodules, and then pseudofolliculitis. Then, if you take the biopsy of these patients with the erythema nodosum of Behcets, it shows that it is secondary to vasculitis. And this erythema nodosum, it is seen in patients with sarcoidosis and as well as inflammatory bowel disease. Then how do you differentiate that of erythema nodosum of Behcets? In erythema nodosum of Behcets, they have the tendency to ulcerate, which is not seen in inflammatory bowel disease and sarcoidosis. And this erythema nodosum, which is a tender nodules, they are commonly seen in the lower limbs. And in order to confirm the Behcets, the test what we do is Pathergy test. Central nervous system involvement will be in the form of sterile meningitis, cranial nerve palsy, seizures, encephalitis, mental disturbances, and spinal cord lesions. Gastrointestinal tract manifestations will be in the form of ulcerations of ileum and as well as the cecum. Vascular involvement will be in the form of pulmonary artery vasculitis, and hypercoagulability is very commonly seen within the veins. And that will be in the form of deep vein thrombosis and as well as the pulmonary emboli and cerebral sinus thrombosis. And joint involvement, it is non-deforming arthritis, and it is monoarticular or polyarticular arthritis. Right? And lastly, the pulmonary involvement will be in the form of pulmonary artery vasculitis, due to which the individual can have dyspnea, cough and chest pain. So if you see a question here, all of the following are the features of Behcets except recurrent aphthous stomatitis, multisystem involvement seen only in tropics, common in youngsters. So recurrent aphthous stomatitis is correct, multisystem involvement is correct, common in youngsters is correct, but the question asked is except. So seen only in tropics is incorrect answer. It is seen both in tropical and as well as the subtropical countries. Then Behcet syndrome is characterized by all except myocarditis, pyoderma gangrenosum, genital and oral ulcers, thrombophlebitis. So vascular involvement will be in the form of thrombophlebitis. Genital and oral ulcers are very common, but what is that not seen in Behcets is myocarditis is not seen, and as well as the pyoderma gangrenosum is also not seen in patients with the Behcets. Right? And if you see the life expectancy, right, if you see the life expectancy in Behcets, life expectancy, it is normal, right, and only Serious complication that can be seen in Behcets will be blindness. Right, development of blindness. This is what you have to remember regarding Behcets. Okay, next, how will you diagnose the Behcets? If you take the laboratory findings, as such there is no pathognomic laboratory features of Behcets. And definitely, because it's an inflammatory disorder, the acute phase reactants will be elevated. Right, acute phase reactants will be elevated. Okay, and what are those acute phase reactants? Like ESR and as well as CRP. Both of them, they are elevated. Okay, and there is no autoantibody here in Behcets. Right, there is no autoantibody in Behcets. But only thing, you have to look for the HLA. Behcets is known to have genetic risk factor. So you have to look for the HLA B51 or B5. Okay. If this is being present, then we can suspect the presence of the Behcets. Then how do you treat these patients? So if you see the treatment, one of the very important drug is colchicine. And this colchicine, the dosage is around 0.6 milligrams. It has to be given once or thrice daily, and that too given orally. Why is this colchicine given? Mainly for reducing the pain, right? In patients with Behcets, they can have arthritis. Okay, so to reduce the pain, you can give this colchicine. And another very important drug is your topical corticosteroid. Okay, so topical corticosteroids will reduce mucosal findings, right? That oral ulcers, genital ulcers, erythema nodosum, then the acneiform eruptions, all that can be reduced by your topical steroids, right? And apart from topical steroids, even oral dexamethasone can be given. And this oral dexamethasone, it should be given 1 milligram twice daily. 1 milligram twice daily. Okay, so this oral dexamethasone or topical steroids, they will reduce mucosal finding and as well as they also reduce the cutaneous finding. Next, another very important drug is apremilast. Apremilast, it is a selective phosphodiesterase 4 inhibitors. Right, it is a selective PDE4 inhibitor and it is an FDA approved drug for the treatment of oral ulcers. Right, it is an FDA approved drug for the treatment of oral ulcer in Behcet's disease. Then, followed by that, if you take these corticosteroids, that includes prednisolone. This prednisolone, right, this prednisolone, the dosage of this prednisolone is around 1 milligram per kg per day. This has to be given for severe disease manifestations. Right, for severe disease manifestations, this corticosteroids, that is oral prednisolone, it is a mainstay of therapy. And next important drug is the azathioprine. This azathioprine should be given at a dosage of 2 milligram per kg. Okay, and this azathioprine, it has the steroid sparing effect. Right, it has the steroid sparing effect. That is about your azathioprine. And in those individuals with severe ocular and central nervous system complications, what is that you have to give? You have to give the monoclonal antibodies like infliximab, right? And another important drug is cyclosporin, Then we have cyclophosphamide. Okay, so these are the drugs they are given for severe ocular and central nervous system complications of Behcets. Then, what are the essentials of diagnosis finally? First and foremost, recurrent painful oral and genital aphthous ulcers. Erythema nodosum like lesions will be there. Positive Pathergy test, anterior or posterior uveitis, and this posterior uveitis may be asymptomatic until significant damage to the retina has occurred. Neurological lesions, they may mimic multiple sclerosis. So these are some of the essential points which are required for the diagnosis of Behcets. So this completes the very important topic, that is Behcet syndrome. And treatment, if you want me to revise once again, let me tell you, colchicine, it will reduce the pain, right? And topical steroids, that will reduce the mucocutaneous symptoms. Apremilast, it's a selective phosphodiesterase 4 inhibitor and it is an FDA approved drug for the treatment of the oral ulcers. And the prednisolone 1 mg per kg per day should be given if there is severe disease manifestations. And if the individual unable to tolerate the steroids, we give the azathioprine. And in those individuals for severe ocular and CNS complications of Behcets, we give infliximab, cyclosporin and then cyclophosphamide. So this completes the discussion of this very important topic, that is Behcet syndrome. Thank you very much.